Thank you so much for the kind words and the invitation. It's a pleasure to be here this morning. So I will be talking about the baseline I-ELCAP coronary artery calcium score and how it predicts 25-year mortality. So this publication came out earlier this year describing that exact phenomenon. And the purpose of this study was to determine whether the I-ELCAP coronary artery calcium score predicts cardiovascular and all-cause mortality after long-term follow-up. In other words, is this test like a crystal ball or like tarot cards that can predict 25 years into the future? The methods for this study involved 8,782 lung cancer screening participants aged 40 to 85, current or former smokers. National Death Index follow-up was used to track the outcomes, and ordinal scoring of coronary artery calcium was performed, and they were categorized as either a score of 0, which is a low-risk category, equivalent to an Agatston score of 0. Agatston is the traditional cardiac calcium score exam using ECG gating. The ordinal score can also be in the intermediate risk category, which is a score of 1 to 3, equivalent to an Agatston score of 1 to 400. And the ordinal score of 4 to 12 corresponds to the high risk category with an Agatston equivalent of greater than 400. For those of you who are not familiar with the I-ELCAP coronary artery calcium ordinal score system, it's actually very simple. We essentially try to look for the coronary artery calcifications on the CT, which looks like this. And if a third of the coronary artery is involved, the major coronary artery is involved, that'll be a score of 1. It would be a score of 2 if a longer length of the coronary artery is involved, meaning 2/3 of it. That would be a score of 2. Score of 3, it's even longer than that. And as we add more segments from different coronary arteries, the score goes up. And finally, the maximum score if numerous coronary arteries are calcified, as we can see in this example, we can have a maximum score of up to 12. The different scoring systems have also been well established in terms of the patient management. So for the Agatston scores, which are, again, the ECG-gated CT scans that are dedicated for cardiac imaging, certain statin recommendations have been put forward. And there's an equivalent management also for the visual scoring systems, depending on the amount of calcium burden is present. And you can see that they're both divided into quartiles. So one of the additional methods for this study was to assess the cardiovascular and all-cause mortality rates. Hazard ratios using Cox proportional hazards regression models were also used and adjusted for age, sex, pack year smoking, and diabetes. Finally, Kaplan-Meier survival curves were generated. And here's some of the data that has been published in that article, which shows an adjusted hazard ratio, which increases with increasing burden of calcification of coronary arteries. And that's a follow-up of about 7 years. And subsequently, with this follow-up to 2024, which is the up to 24-year follow-up, you can see that the hazard ratio similarly increases with increasing burden of calcium score, simply based upon the baseline coronary artery score. And that's for cardiovascular death. So I want to point out the same thing was done for all-cause mortality. With increasing coronary artery calcium scores, we have increasing hazard ratios. And on longer-term follow-up, we have very similar data showing, again, increasing hazard ratios with increasing burden of coronary artery calcification on 24-year follow-up. Again, that's for all-cause mortality. So here we have the cardiovascular specific survival curves, Kaplan-Meier curves, showing you the survival probability in the y-axis, and x-axis is number of years follow-up. The blue line is the line representing subjects or individuals with no coronary artery calcification, red line with mild or intermediate risk, and the green line is the population with higher calcification scores of 4 to 12, meaning a high-risk group. We see similar curves with more drastic changes in survival in all-cause Kaplan-Meier curve, again, with the blue line demonstrating the patients with 0 calcium score, red line calcium scores of 1 to 3, and calcium scores of 4 to 12, which is the highest risk category with a much lower all-cause survival. One of the things that's interesting in this study, which is initially when I saw this seemed counterintuitive, is if you divide the patient populations according to age, with one group being less than 60 years, another group 60 to 69, and another group 70 years and older, what you'll see is that the hazard ratio is actually much higher for the younger age group. So this less than 60 years has a hazard ratio of 4.61 with the highest category of calcification, as opposed to a hazard ratio of only 2.0 or 2.1 for ages 60 to 69, and hazard ratio of 1.68 at age 70 years. When I first saw this, I was thinking, isn't coronary disease and death supposed to be more prevalent as you get older? But here it shows the hazard ratio is higher for the younger group. So it turns out one of the reasons this is probably the case is because if you're less than 60 and you have severe coronary artery calcification, that implies that you have premature atherosclerosis or early atherosclerosis that is greater than expected for your age. And so that's very abnormal. And so it's actually incorrect to think that, oh, it's worse as you get older. But it turns out if it's really bad already and you're 60 years old or younger, that's something that we need to focus on as well in terms of preventive medicine. So comparing the I-ELCAP data to other studies, so here is a study performed on 717 chest CTs. This is published in 2023, which demonstrates all-cause survival using non-gated Agatston scores. So they actually quantified the calcifications here, but divided them into quartiles as well. And what we see in this study is actually quite interesting, is that patients with no calcification actually did worse than people with mild calcification. And people with moderate to severe, there's a lot of overlap between these. The ones with severe calcification did worse. But one of the things to remember with these types of studies, looking at all chest CTs, is that these patients have different diseases. For example, some of these patients had severe infections, late-stage cancers. So these are just all patients with chest CTs for any reason who happen to have Agatston scores performed on them. And so there's a lot of confounding factors that would affect the survival curves. One thing you also notice is that even the individuals with a zero score, which is this green line at the top, end up having really much lower survival, 0.9, at only less than 4 years. And you can see that at our 4-year mark, most patients here with no calcification had much higher survival rates. And again, the reason is because the I-ELCAP group tends to be patients with either no symptoms or don't have advanced disease, compared to just a potpourri of chest CTs from people with various comorbidities. And here's another study looking at 536 chest CTs in patients, all of whom had stage 1 lung cancer. This is also published in 2025, actually. And looking at all-cause survival by non-gated Agatston score. So they used Agatston scoring system again, divided them into quartiles. I think the battery might be running low here. Anyway, the point is, I think, out of juice. Oh, oh. Anyway, what we can see here is that the survival curves are, again, much lower than what we see in the I-ELCAP population, because these are people who already have cancer, as opposed to the I-ELCAP population, many of whom have no previously diagnosed cancer. This same study, which looked at 536 chest CTs of patients with stage 1 lung cancer, also looked at the effect of blood tests on risk stratification. You can see the blood test performance is much poorer, and the blood tests involved multiple inflammatory, immunologic, and metabolic markers, as we see listed down here. Another group looking at chest CTs, this time using ordinal scoring, also found very useful information, risk stratifying patients by the severity of calcium and survival. And when they compared the effectiveness of coronary artery calcification risk stratification compared to thoracic aortic calcification, they find that the calcifications in the aorta are relatively poor predictors of survival compared to coronary artery calcium scores. One recent study as well from 2022, again demonstrating a difference between survival in patients with higher calcium scores with lower calcium scores. Again, much lower survival rates because these are a group of chest CT patients who had various diseases. So a lot of comorbidities. And then looking at the hazard ratios compared to other exams, you can see that the hazard ratios reported by many studies are much higher than those in the I-ELCAP group. So all the boxes in red are basically hazard ratios of 3 or greater with higher calcium scores, whereas with the I-ELCAP group, you can see highlighted in blue, the hazard ratios are much lower. Again, that's because a lot of the other studies have many comorbidities in their population. So I want to mention some limitations in the study. There's a potential for a coronary artery calcification misclassification if using older CT scans, either thick slice thicknesses, lack of ECG gating obviously will cause motion blur, and the low radiation dose also may introduce noise that might end up being calculated as calcification when there might not be any. It's also very well known that the negative predictive value of a 0 score on a non-gated CT is only about 80 to 90%. And that could be important if you're using a calcium score of 0 as your reference, because we might call something as a calcium score of 0 when there really might be a small amount of calcification there that would affect the patient's outcome eventually. We also know that statin therapy can increase calcification while lowering cardiovascular event rates, and that ordinal calcium scores can be improved by automated AI software, which is now most of which are FDA approved. So in conclusion, a baseline coronary artery calcium score is strongly predictive of cardiovascular disease and all-cause mortality in up to 25 years. Combined early detection of cardiovascular disease and lung cancer presents a major opportunity to advance public health and preventive medicine, especially in this era of AI-powered automation. And with that, I'd like to thank you for your attention.